Everyone, it is 10:30-ish. House Healthcare on what day are we? Thursday, May 15th. Halfway through the month. I was just about to quit halfway through the legislative session. People would probably be mad about that. All right, so anyways, we're gonna have a walkthrough from Jen on H482, which it's my understanding it is still on the Senate calendar up for action. And hopefully they get to that today or today. But she'll walk us through the changes of set 480 that was made to 482.
Good morning, Jen Carvey, Office of Legislative Counsel. Yes, we're going to look at 482, the markup from the amendment recommended by Senate Health and Welfare, because that is, as far as it's gotten, the bill is on this, as the chair said, on the Senate calendar. It is still up for second reading. Don't know if it will come up today or not. So let's look at, oh, I have to join the Zoom. That's the part I forgot to do before I got up here. We'll look at the language. So as usual, I've done a markup version showing what passed the House with the Senate Health and Welfare proposals included as. All right, here we go. This is 482, as I said, showing markup from the Senate Health and Welfare Amendment. 482, as you may recall, is an act relating to Green Mountain Care Board authority to adjust a hospital's reimbursement rates and to appoint a hospital observer. So the first section is on reduction or reallocation of reimbursement rates and risks to health insurer solvency. So no changes to the definition section as you sent it over. This, again, just to orient us, is the language allowing the Green Mountain Care Board, after consultation with the financial regulation, Commissioner of Financial Regulation, if the board determines that a domestic health insurer is facing an acute and immediate threat to its solvency because of its risk-based capital levels, the board can order a reduction of the insurer's rates to one or more Vermont hospitals until such time as the insurer's risk-based capital level exceeds a higher threshold. This adds in language specifying, and this will look familiar from our work on S63, but just to be clear, sure there are no ambiguities, notwithstanding any provision of 3 VSA Chapter 25 to the contrary, the board's activities under this section shall not be construed to be a contested case. Any person aggrieved by a final board action, order, or determination under this section may appeal as set forth in the board's appeal statute. In subsection C, the board, they didn't change the criteria for a hospital to be eligible to have its reimbursement rates reduced under this section. So a hospital must have at least 135 days cash on hand and have had a positive operating margin in the previous fiscal year, or be part of a hospital network that has more than 135 days cash on hand, or a positive operating margin in the previous fiscal year, or both. They did in this provision, I just took out the sub and made it a section. It's really more of a stylistic change, but the board shall order a reduction of reimbursement rates to a hospital pursuant to this section, still only to the extent necessary to remediate the threat to the domestic health insurer solvency. And this adds language saying, in determining whether and to what extent to reduce a hospital's reimbursement rates, the board shall consider the competing financial obligations of the hospital and of the domestic health insurer. And this is to address some concerns raised by the hospitals that they might have financial obligations that would be negatively impacted by a reduction in their reimbursement rates, or really a reduction in their days cash on hand. And so this is directing the board to look at kind of what the risks are around the hospital's financial obligations, but also the health insurer.
Is this the part around sort of maybe like their bond rating would go down.
Exactly. Yep, that's an example of one of the issues, the bond covenant issues that the hospitals were raising, and the board came back and said, but if it's a question between reducing hospitals' bond rating and having our domestic health insurer go out of business, they may look differently at those prospective harms and the harms to the people of the state. Also specifies that the board shall provide a hospital with the opportunity to request relief from a rate reduction ordered pursuant to this section. And then just renumbered number 4 about not reducing projected days cash on hand below 125 days. Section 2 is the hospital budget review process and some modifications here under the first item. And this was a proposal from the board to change. So you'd had in the version that we'd worked on in this committee, it had struck that individual hospital budgets shall reflect budget performances for prior years. And it said, instead said, shall reconcile any significant deviation during the previous fiscal year in excess of the budget established for the hospital pursuant to this section using a methodology established by the board. And this is kind of addressing that in subsection H, there is the ability for the board to, get in there, or else that's the enforcement section. So if not already addressed through enforcement, the hospital budgets must still reflect budget performances for prior years, and if not already addressed pursuant to subsection H, account for any significant deviation in revenue during the, and then change previous to most recently completed fiscal year, which is likely the same, in excess of the budget established for the hospital. So not necessarily different in concept, but recognizing that there are other ways that accounting may have occurred already.
How far?
Go ahead. I'm sorry. What?
It says reflect budget performance for prior years. How far back? I mean.
In practice, I don't know. This is existing law. So I don't know what that looks like for the board. Then in subsection F, they made no changes to the allowance for the board on its own initiative to adjust commercial rates to ensure that a hospital stays within its budget. And in subsection G, this is the hospital observer language, allowing the board to appoint a hospital observer under certain circumstances. And this, they added language specifying that the independent observer shall be a person with experience and expertise relevant to the specific circumstances. I think that was the only other change.
Okay, so not really that much. Any questions from anyone? Go ahead.
Yes, I don't know if it's a question, but I think I just read there, the independent observer shall be a person with experience, expertise relevant to circumstances. Well, the board gets to pick this. And then if you read down a little further, the board may order the hospital pay for all portions of the cost of independent observers. You know, that gives the board quite a lot of leeway and at no cost to them.
Well, they can only appoint an observer upon finding that a hospital has made a material misrepresentation in information or documents provided to the board, or that it is materially non-compliant with the budget established by it. So the circumstances are reasonably narrow.
Yeah.
Yeah.
And we were, I mean, our version had that essentially it was sort of a bill back.
Right.
Leslie.
This is more of a comment. I think that this narrow part is really crucial. We've been getting, or I have anyway, from hospitals down in my area saying, we're gonna have to pay for all this stuff. But it seems like the understanding is that they would have to be materially misrepresenting themselves. And are they planning to do that? And therefore, are they fearful that they are already doing it and therefore freaking out? So I'm a little confused. about the response that I've been hearing from hospitals in my area about are they really not reading the bill? Or are they trying to, I don't know what's being addressed.
I'm gonna let Devin say something, but first I want to ask Jen, can you sort of give us a plain language for people who don't work in legal fields, on what sort of the legal meaning of material misrepresentation, material non-compliance? What does material even really mean?
I'm not sure off the cuff, I can't. I mean, material has to be something that matters. It's not just that that there was a typo or that it was an insignificant change, de minimis to use another legal term, but if it's minor, it doesn't matter much, or it doesn't have a real impact on anything, I think it would likely not be material. So being material, I would have to let the board tell you what threshold they would consider materially non-compliant at what level of non-compliance does it become materially non-compliant? But they have other remedies as well. I don't know that they would find an independent observer necessary. This is permissive language, so I don't know that the board would find it necessary in all circumstances in which a hospital is materially non-compliant with a budget to appoint a hospital observer to go in and figure out what's going on. It might just be a matter of an enforcement action. So this is, I would say, another tool in the toolbox. I think it may be more the or the material misrepresentation. Again, is it something that is insignificant, an error, something that is explainable, or is it clearly a misrepresentation by itself is already sort of going down a path of intentionality. But material misrepresentation, I would say it has to be of some level of substance.
I think the word intent is really.
Well, I would say in misrepresentation. I don't know if it's, if a hospital is materially non-compliant with its budget, I don't know that. That doesn't have an intent element. Non-compliant just means you're not
following the rules.
Right. But making a misrepresentation, I think there's likely to be intent, or at least perceived intent. But it's really in how the board would execute the authority it's being given.
It's too bad this couldn't be more laid out, in which the board would appoint someone. I could see if a hospital is going bankrupt, then you'd want the board to step in and to take charge and try to correct things, such as an overseer of some sort. But this seems to be a little bit too much for me anyway.
Is this the language that was passed out of
I know.
this committee and this body? So this is not new from the Senate,
I don't think.
but that's fine. You don't have to support.
No, I don't think I was here when.
You're in Canada.
We did hear about it, though.
Yes.
Yeah.
And I would say also, if a hospital is going bankrupt and the board appointed someone to oversee it and take charge of the hospital, I could see where the hospital would pay for, the salary of that person and expenses and things like that. But just to go in because you've missed your mark on your required budget, it just doesn't seem right.
So I actually think it's more likely that there would be that the board would order a hospital to pay if there had been, whether misrepresentation or material non-compliance, but if the board was concerned that there was inappropriate activity occurring, if the hospital was in a bankruptcy or insolvency situation, it may not be useful to charge them additional money they don't have to pay, but that would be up to the board.
And what do you have a board of trustees for? They're supposed to be pretty much responsible for the organization. And
Can I just I just want to reset a little bit.
Okay.
And the bill in its context. First of all, there is absolutely nothing currently that allows Green Mountain Care Board to go in to a hospital that is facing financial difficulties and oversee them. I mean, there's a difference between oversee and observe, and there's nothing in this language actually, remember that the only trigger for this is that the only way this can happen is two circumstances. An insurer is facing imminent insolvency.
It's not the observer piece. The observer piece is material misrepresentation or material noncompliance with the budget,
But
all in the budget context.
But doesn't the hospital need to be in a fiscal situation? A positive fiscal situation?
Sections 1 and 2 are not
Okay.
connected.
I'm sorry, you're right.
Had the same issue in the Senate. So yes, so section 1, where there's hospital has to be in a certain situation and an insurer is at risk of insolvency, is one piece.
Okay.
The observer is in the context of the hospital budget authority.
But they can only observe. They don't get to change anything. They don't get to take over anything. They don't get to
They can
run the
monitor
hospital.
operations, obtain information, and report findings and recommendations.
They don't actually get to do anything.
And I think we had changed the word from monitor to observer because there was some concern about whether a monitor could have a more active role.
The question is, what's the authority of the observer? What will that observer going to be doing?
Shows,
So they may monitor the hospital's operations, obtain information from the hospital, and report findings and recommendations to the board. They have a right to receive copies of all materials related to the board's hospital budget review. Hospital has to provide any information requested from the observer, including any information about the hospital's participation in a hospital network. The observer shares information with the board and with the Office of the Healthcare Advocate, but does not otherwise disclose anything confidential or proprietary.
so they're not,
But a lot of that information the hospital's already provided, hasn't it? To the board previously.
true, except also, again, the trigger is if there's a material misrepresentation or a material non-compliance.
Again, it would be nice if we had a better definition of what material, what's the key word?
Misrepresentation.
Yeah. What is material misrepresentation?
Significant lie.
I mean, I think it's, you're giving the authority to the board. They have to determine when they believe a particular fact pattern reaches the level of material misrepresentation or material noncompliance. A hospital can appeal that.
So the hospital, if the board finds something that they say is material, oh my gosh, there's gonna be another word I can't pronounce, materially non-compliant or material misrepresentation, does the hospital have any sort of way that they can say to prove that they haven't been, can they appeal it in any way?
They can appeal any final order or determination by the board. I don't know what the implementation would look like, so I want the board to weigh in on how they would make this finding. But in general, everything that the board does that affects the regulated industries is appealable
So
under 9381.
So this section, this new language about appointing an independent observer. It would fall under the duties that the board already has, and it would fall under the 9381 appeals process. So a hospital could appeal the decision to appoint an independent observer to the Supreme Court.
I believe so. I would, I think it would be helpful to have the board confirm, but
And
so. I mean,
if that was the case, though, then wouldn't the Supreme Court make the decision whether or not something was materially non-compliant?
They would have to see, they
Misrepresentation.
would be reviewing the board's determination.
Yeah. Okay, somebody else had a question. I thought a hand up. Oh, Devin. Yes.
Devin Green from VOZ. I would just say on the independent monitor piece, we are not worried about the materially misrepresentation piece, we're not hiding anything like that, I can stay in. What we are worried about is the materially non-compliant with the budget orders piece. As you know, doing state budgets don't always come in at their target. This is why you have the Budget Adjustment Act every year. And here, the Green Mountain Care Board in testimony, originally when this bill was passed out of this body, I will recall it was passed very quickly, and we didn't have the definition of materially non-compliant. The example the board gave was like a Springfield situation or something that was a very bad situation. In the Senate, the board defined materially non-compliant with budget as not meeting your budget orders. And that can be as low as something as 1.91% off of your budget. NVRH got a letter last year saying that they were non-compliant with their budget orders. And so that is the concern of our hospital, is that if you just miss that target by a little bit, the Green Mountain Care Board can appoint a monitor that you have to pay for. And we don't know what the cost of this monitor is. The one for UVM is $15 million. We can't even afford to pay a fraction of that. And so that is the concern that we have on the monitor piece. We have another concern too.
$15 million.
Why would it be that?
I thought the agreement was up to,
Up to $15 million, that's right.
I thought it was 13, but maybe.
Even that.
But wasn't that UVM's proposal?
That was the agreement that came out of the Green Mountain Care Board and
Which UVM,
agreed. We're
Agreed.
not arguing that proposal. We just don't know how much these monitors will cost. If it's something like the hospital missed its budget target, we think that, first of all, we don't think that that's the right criteria. It should be something like really substantially off of your budget, not something like a little, like 1.91%. And also, but if that is going to be the criteria, then perhaps the state should pay for it so that there's some parameters on how often this is used. If the hospital is paying for it, you know, there are no parameters, especially if we're defining materially non-compliant as not meeting your budget orders.
Ellen,
So for 13 or 15 million dollars, and that's gotta be just for 1 year, because each year it's a different budget, right?
Yes, and that's UVMNC, that's the
Yeah.
UVM Health Network, which is, we're not anticipating every hospital being that much
No,
money.
but
We
still,
also don't know how
so
much.
if there's a time period, this monitor ain't gonna be there for the next 10 years.
I don't know how long the monitor stays in there.
Under this.
Oversee how long it's
Yeah,
been there.
yeah.
Wendy,
Isn't there a process though, that as the budget, if you have a set budget, this is my understanding, that if it starts to run hot, as they say, then you renegotiate the budget so that there's.
So the current process is if you miss your budget, the Green Mountain Care Board, you can report to the Green Mountain Care Board. Let me go back and think. Okay, so the current process is there's an enforcement process. So the Green Mountain Care Board can go in and say, you've missed your budget. And this is what we're going to do to enforce your budget. That is already in place. There's another provision in here in section 2 that allows the Green Mountain Care Board to adjust the reimbursement rates at any time in the budget cycle if the hospital's off the budget. And I think that creates a lot of instability because budgets fluctuate throughout the year. And it's really worth waiting until the end of the year before enforcing a budget. I think the process they have now makes more sense.
Leslie?
If I remember right, we heard testimony that budgets have not been enforced over many years. And because of that non-enforcement, we're in the situation we're in now. So I think we remember how we got here and that we do need some controls. And I mean, nothing's forever, obviously. I've learned that here. But at least in the short term, until we have better solvency in various sectors. I mean, we have 9 hospitals in the red, we have an insurer insolvent. We need to take someone in this world, and it appears to be us, needs to take hold of the situation, and this is the path. And I think that's important. So that's a comment.
Thank you for that comment.
Evan Green from us, I'll just say that there has been enforcement over the years. Northwestern Medical Center was enforced in 2018, their budget. Their rates were adjusted down and they have not fully financially recovered from that. So there has been enforcement. It's not like the Green Mountain Care Board doesn't already have the tools. And when this bill is being talked about, it's being talked about as very narrowly tailored, maybe only affecting 3 hospitals. I just want to make clear that this impacts all hospitals potentially.
Does this authority is repealed?
The observer authority, yes, is repealed in 2030,
2030.
January 1st, 2030.
So for 4 years, essentially,
Four and a half.
4.5 years. And then it's gone, unless we decide to.
Right. Unless the future legislature extends it.
Okay, any other comments, questions? Mari. Oh, well, Mari, go and then Winnie.
I'm gonna add to Leslie's comments by saying that the Green Mountain Care Board has powerful interest in making sure that our healthcare system corrects and is sustainable. And that includes the hospitals, and for that reason, and from the testimony we've received, I trust that the Green Mountain Care Board will behave reasonably with the whole system, including hospitals, in mind.
Yeah, I mean, we'll echo those comments and yeah, okay, maybe I'll say the quiet part out loud. I'm not sure why the vast majority of our hospitals are struggling mightily to stay afloat. And frankly, the Green Mountain Care Board is doing everything in their power to keep them afloat. I mean, if you look at the budget orders the Green Mountain Care Board has made of all 14 hospitals, the argument could be made that a lot of them are there because of the Green Mountain Care Board. And we are in this situation because there are some hospitals who frankly are not thriving as well as they should be because the resources are being gobbled up by other hospitals. And as Leslie said, if no one else will make the hard decisions, it seems to fall maybe on this committee or the legislature to make the tough choices and the hard decisions. And these are hard decisions and unpopular. But I have this sense of, I don't understand why the very hospitals that will benefit from this are like fighting against this. That I do not get. I just don't get it. I mean, if anyone can show me evidence that the Green Mountain Care Board has materially tried to hurt the finances of any hospital in the state at any time, the present board, past boards, then show me that evidence. I haven't seen that. I think they're struggling mightily to correct a healthcare system that is crumbling or going off a cliff or on fire or whatever metaphor we've used over this past session. And I'm sorry, if they think they need this, then I'm in favor of it. So, Woody.
I'm not gonna argue with you. I don't think hospitals feel that that the Green Mountain Care Board is out to, to get them or anything like that. But I do think that there is some concern over the authority that the Green Mountain Care Board is receiving more and more. And I'll just leave it at that. I do have a question regarding S63 that we passed some time ago regarding due process. How does that work in this case with this bill if the hospital feels that it shouldn't have an observer and they haven't done anything out of line? Is that the right bill that we?
You mean a contested case?
Yes.
Case? So we didn't put in, there's nothing specific in this section. The language about it not being a contested case is on the reduction of reimbursement rates when a health insurer is at risk of insolvency. But regardless of whether something is a contested case or not, there are lots of ways of providing due process beyond a contested case. Process is a particular sort of set of parameters and circumstances, but it's not the only way to provide due process.
So the hospitals do have a way of obtaining. due
Challenging an
process.
observer.
Yeah.
I believe so. I mean, that's going to be up to the board to ensure they are providing an opportunity for process. But generally there are, we looked at 9381 as the board's appeal statute. And anybody who is aggrieved by who goes, well, let me pull it up instead of trying to remember. What?
By a negative decision.
Right. Well, not negative.
Let's let Jen read 9381. I feel like I've read that piece of statute a million times. While she's pulling that up, I thought it was kind of funny, Woody, you said when we did S63 some time ago, I'm like, that was yesterday.
It was this week.
Yeah, that was yesterday. We yesterday.
Not to me, it doesn't.
Leslie, did you want to?
Well, I could just.
Jen's bringing up
Yeah, while
language.
she's working on that, continue this conversation. When Springfield Hospital went bankrupt in 2019, it required $12 million of money from the general fund to keep it open. That's $12 million that didn't go elsewhere in our state. And Springfield Hospital, as far as I can tell, is basically trying to do the same thing. You mentioned the Board of Trustees. I think that's crucial. About doing the same thing, expecting a different result, not happening. So it's still in the red, right? And along with many other hospitals, someone needs to be in charge. And that's what I care about.
Would The healthcare advocate, because I know that you had sort of testified to this actually when we were first doing, it. Can you remind us of what happened with Springfield? Because I think you were here at the time.
Yeah, Mike Fisher, the one detail that comes up for me in my memory of it was how much it caught all of us by surprise just a few months after the hospital budget process. And so, in the hospital budget process, their days cash on hand look pretty good. The measure that we use for how well a hospital's doing. Now, we didn't learn until later that their days cash on hand looked pretty good because they hadn't been paying bills. So, I'll just go to the, I totally understand the concern from hospitals about the big bad regulator, and I totally understand why it makes sense for the hospitals. I get their fear. But I also feel like we are in just a level of crisis at this moment and a level of need for a regulator that can really address what is playing out. And I think, if my memory serves me right, Owen, chair of the board, said a 1% variation for budget was not a materially non-compliant with the budget. That's my memory. I have to go back and look at the tape. I think we're talking about something really different here. And, if you've been watching this process for long enough, and if maybe I should just stop myself. I think this bill is good, an important piece of making sure that the board has the tools to manage the situations we're in now.
Thank you. Jen, do you want to put up 9381?
Sure. The 9381 requires the board to adopt procedures for administrative appeals of its actions, orders, or other determinations that provide for the issuance of a final order and create a record sufficient to serve as the basis for judicial review. Any person aggrieved by a final action, order, or other determination of the Green Mountain Care Board may, upon exhaustion of all administrative appeals, appeal to the Supreme Court. So as I read it, a finding of a material misrepresentation would be a determination. Material or material noncompliance would be an other determination. I'm not sure if it's literally a final action or order, but it does seem to be an other determination.
And appointing an observer could be considered an action.
Yes, but I think it's the finding that triggers that they would be challenging more than the authority of otherwise it would just be about it, the authority of the board to appoint an observer.
Yep. Topper?
So they have two ways to appeal. One is the Green Mountain Care Board process, and the other is Supreme Court.
Right, so the initial appeal goes through sort of an internal, and this is the way a lot of state government works. You first appeal to whoever the decision maker is to say, I think you have made a mistake and here's why, or you're not looking at all the information, please reconsider. And then if they are dissatisfied, there is also then the record of that administrative agency's kind of redetermination that serves as the basis for the appeal or the record for the appeal.
Can I just
Of
make a
course.
statement?
Please.
Woody, I'm gonna make a statement. Tell me how, if I'm on base or off base, okay? As I sit here and listen to this conversation and other conversations that I've had outside of it, you think that us other people and be able to do a good job, or are they considered the enemy? Because I'm at the point where I'm trying to figure out.
I would say in the past, it has been considered the enemy in many hospitals, okay? I will say this about the current board. I think the current board has a very good leader, a very fair leader, in fact. that may change in the future, you know, but right now, I think the board is doing some good things with its leadership, okay? But it does have some bad
Okay,
history.
okay, so, as I sit here, then I'd say,
There are many people that would like to get rid of the being up
Yeah.
here.
as I sit here, I say to myself, we're in a terrible situation right now. And, we have somebody who's considered a good leader in the Green Mountain Care Board. And I understand, statements about that he may not be there for, we don't know how long he's gonna be there as the leader. But, right now, I would say that he's the kind of leader that we need. And we should trust him and the board at least through the next couple of years. Where these pieces of legislation are being put into effect that allow the chair and the board to do certain things to help hospitals stay solvent, to help payers stay solvent. And if I'm off track, you need to tell me right to my face, because that's the path I'm going down.
I know where you're going, Copper. And I know where this committee is going, and that's fine. I mean, but we all have different opinions.
Yes, I understand that. And that's what.
And I'm fine with that. That's
Sure.
part of our process.
So am I. And that's what we have committee discussions for. Okay, so,
Thanks. I looked up the board membership and just for your sake, the current chair of the Green Mountain Care Board's term ends in September of 2030, which happens to be the same time that this server ends as well in statute. Alan, and then I think we're gonna move on.
Just to talk to Topper, you gotta realize the general public, the taxpayers, the patients of these hospitals, they're sitting there and they're hearing all these things where my hospital is going to lose this, my hospital is going to lose this. And they don't have a good sense of the Green Mountain Care Board, whether it's warranted or not. Okay. So that's part of it. And the other thing is now, so we're putting all our eggs in one basket here. It better work. So.
I agree, Penny. And those eggs have been in that basket for a while.
Breaking.
And what's
So-
the alternative?
Yeah.
The alternative is the system crashing, Blue Cross leaving, we've done nothing.
Well,
And I don't think that they would disagree with the characterization that the Green Mountain Care Board is the bad guy.
well, I
think
didn't say
the Green
that.
Mountain
either.
Care Board has made decisions that specific entities in our healthcare system may not like, but it's the only entity that has the whole healthcare system in mind and not just its own proprietary interests. And that's what's gotten us into this mess, not just in Vermont, but nationwide is, like I was saying a couple weeks ago, following the money is a rational thing for companies to do. And in healthcare, it's Byzantine, and there are really wild and creative ways to try to grab the healthcare money, because you never know when things are going to change, and you're not going to have that money anymore. But there's only one organization that has a view and an interest in protecting the whole system, including payers, hospitals, patients,
Vermonters.
Vermonters, and that's the Green Mountain Care Board.
I think I'm gonna, let's remember, we don't even have this bill yet because it's still on the Senate calendar. Let's hope they get to it today.
It's not on their calendar.
It should be on their calendar.
Oh, really? I just looked, maybe I missed it. Sorry.
Unfinished action from yesterday.
Oh.
Yeah, and
oh,
remember,
I
we
looked at the-
remember
I
we
looked at the
finished
committee, I looked
things,
at
the
the-
Senate tends to be like,
Senate floor.
it's
Okay.
I look for us to end, and then they end. So let's move on, if we could, please, to H 266. And when we get what I was going to say about 482, when we get it back, we will certainly, and we will take testimony, more testimony on it. people wish, because it seems as though we really have, we want to make good decisions. We'll seek out getting the right voices. So Sarah, if you want to come on up. So we're pivoting to, back to 266, which they did have second reading on yesterday, should be up to third reading today, and we will be getting that back.
Thank you. I'm joining the Zoom right now and turning off my audio. So you asked a very reasonable question. And the analyst at Blue Cross spent some time trying to get you the answer. I have to give some caveats about the data. Okay. And it's on your page, and I will try and pull up for you what we were able to do. So, just a teeny tiny bit of history. I did spend 16 years working in the Joint Fiscal Office modeling data for the legislature. So I'm not unfamiliar with this territory, but I am not the data analyst for Blue Cross and Blue Shield of Vermont. I have a team of people who work on this stuff, and I would say it's very complicated data. I asked them, could we recreate the RAND data for Vermont? And essentially we cannot, for a whole bunch of really good reasons. One is we don't have the data for all the payers in Vermont. We only have Blue Cross. We actually only are using current data. We're not, the RAND data was 2022 and 2021. We're using current data, current ASP. But the biggest difference is we're using actual claims data, not hypothetical information. So we're not averaging every drug that a hospital could administer. We're averaging the drug prices of the hospital that the hospital did administer and that we have in our claims database. So it's different data. I just have to be really clear up front. And for some reason, it's not letting me pull up this right thing.
I just want to do one thing, because I know you only have Blue Cross's data,
Only Blue Cross.
but we don't need Medicare or Medicaid's data, because we know exactly how much they pay. They pay regardless of who bills it, where they bill it, whatever.
Correct. But I don't have MVP. I don't have United. I don't have any other.
Have that other little
player in the system. And what I'll keep talking while I'm looking for this. What I do know is that these are rare drugs that are not administered at every hospital in our system regularly, right? So when we went through our claims to look at the prices, what we found is that this rare and unusual drug is not even sometimes administered in this hospital in the time frame that we looked at. So it's a really small data set. And so averages are very skewed in that kind of instance. So this is the best I can do, but I just really want you to have like a lot of caveats about the data. And I will say that the data from UVMHN tends to be better because there's so many more claims at that particular hospital, but you are very interested in smaller hospitals. Let me see, I am going to pull it up a different way. Okay. Yay. So I'm actually going to start with the second slide because I should have reversed the order. This gives you an idea of the data we're using. So remember the same 5 drugs that I brought the percent of ASP that EVM is charging? Electra, Kanjinti, Neulasta, Remicade, and Ruxience, I think. So I had them go through just for those 5 drugs and give me the percent ASP that the hospitals that we have in our database are charging for those drugs. And the reason that some hospitals have a no number there is because the hospital didn't administer that drug during the time period that my claims show. So the first one I'll start with is Inflectra. I had to send myself an email so I can see what the actual prices is because I can see that they're hard to see. But so Southwestern for Inflectra charges 1,600% of ASP. UVM Medical Center charges 2,312% of ASP. Central Vermont Medical Center charged 1,358% of ASP. Mount Ascutney was 2,481% of ASP. Northwestern was 561% of ASP. North Country was 697% of ASP, and none of the other hospitals administered that drug in the time period that I have. So it gives you an idea of like, there's a lot of variation here. These are rare drugs and they're very, very expensive. So that's that chart. Now I'll go back up to the one you asked for. So the line is showing you the average percent ASP by hospital for the drugs that we have in our database during this time period. And you can see that it's kind of all over the map and it probably changes for every time period, averaging. But that UVM doesn't, on average, have the highest percent ASP that they're charging. On average for my time period, they're 364%. If you look at Mount Ascutney, their average for that time period was 623%. But the bars I put on there are the dollars involved here. So while Mount Ascutney may be charging a much higher percent of ASP, they're administering very, very few of these drugs. So there's not a lot of money involved from our perspective.
Marty.
So not being a math person, so I'm assuming what you just said then means that it takes into consideration or corrects for utilization. The UVM probably administering much more of these.
So these are not weighted averages.
It's just absolute
It's,
numbers.
yeah, it's an absolute number.
Percentage of that.
We talked about weighting them. We couldn't figure out the right way to weight it. You weight it by the most expensive drug, by the one most commonly used. You know, it gets complicated. So there are, that's why I started out with what I said. There are a lot of caveats to this number. We don't have the kind of time that Rand had to do the historic research to do something more accurate. So I just want you to take it all with a grain of salt.
Okay.
Yep. So, and so then I have to note, the data for Gifford, Copley, and Northeastern, we had to estimate. They bill us with a lot of anomalies that made it very difficult for our analysts to identify the unit, the quantity, and match it up to the right percent ASP. So she had to do some estimates for those three hospitals. Because I didn't want to put zeros in because we know that they're administering those drugs, but the information was kind of so inaccurate that I couldn't really use it the way that it was. So those three. And then if there's a couple here like Grace Cottage, I don't think they're administering any of these drugs.
Just a question about this brat. I'm not sure I understand probably being dumb of the portion of money change.
Right. Yeah.
What is that?
I should have explained that. Sorry. And that's probably my weird words. So I gave you all a number, an estimate of $46 million that would be saved by Blue Cross members if you cap at 120% of ASP. So that's if I take that $46 million and divide it by the hospitals and how they would be impacted. So the vast majority, and it's the axis over here on the right is for the bars and the axis on the left is for the line. I should have said that up front too. Apologies. So you can see that almost 70% of that $46 million would be from the University of Vermont Medical Center.
Oh.
That's what it's showing you. Then just over 10% would come from Rutland Regional Medical Center. I think it's 7 or 8% from Central Vermont. And then it drops down pretty dramatically to 1, 2, or 0%.
Thanks for asking that question, Leslie.
Yeah, I'm sorry.
Any questions for Sarah? Thank you. And please, because I know that I just threw this question out here yesterday and I said, get this. So whoever it is at Blue Cross Blue Shield who spent probably their own personal time trying to
Tell her thank you, yes.
We appreciate it. Lovely graphs.
Thank you.
Absolutely wonderful. Thank you. All right, so if Jen wants to come back up, so after our discussions in the last couple days around white bagging and Woody's suggestion about ASP, I had Jen draft some language. And
Send it to Kristen. Do you want?
yeah, Kristen, do you want to post that? And I wanted to sort of get the committee's feel about some language that Jen drafted for us that might get to something we might want to do with 266.
Thinking maybe I'll just put it up from my Word document. Well,
That'd be great.
Kristen handles the posting aspect. All right, so this is H266. This is a potential new section on outpatient prescription drugs and limitations on hospital charges. And this language would, so let's put it in Title 18 in kind of the General Healthcare Administration chapter. A hospital shall not submit a claim to a health insurer for reimbursement of a prescription drug administered in an outpatient or office setting at an amount that exceeds 120% of the average sales price as calculated by the Centers for Medicare and Medicaid Services for the most recent calendar quarter. They update them quarterly. For any drug for which the hospital charged any health insurer more than 120% of the ASP in effect as of April 1st, so as of a past date certain. So a hospital could not submit a claim for more than 120% ASP for any drug for which they did charge more than 120% ASP as of April 1st. For any prescription drug administered in an outpatient or office setting for which a hospital charged an insurer 120% or less of the ASP in effect as of April 1st, 2025, the hospital shall not charge the health insurer a greater percentage of the ASP as calculated by CMS for the most recent calendar quarter for that drug than the percentage of the ASP that the hospital charged the health insurer as of April 1st, 2025. So for anything they were charging more than 120% ASP as of April 1st, they would be brought down to 120% ASP going forward with whatever the ASP is, on a quarterly basis calculated by CMS. For any drug where they charged 120% or less of ASP on April 1st, they could not increase that percentage. So they would stay, so they can't just raise all of the other drugs up to 120%. Then it says the purpose of this section is to reduce healthcare costs. A hospital shall not charge or collect from the patient or health insurer any amount for a prescription drug administered in an outpatient or office setting that exceeds the amount set forth in subsection A, so no balance billing, or increase the amounts the hospital charges for other prescription drugs, procedures, tests, imaging, or other healthcare goods or services in an effort to offset revenue reduced as a result of implementing this section. So don't jack other things up in response. The provisions of this section shall remain in effect unless and until the Green Mountain Care Board establishes a different reference-based price under section 9376, is part of what you're doing in Act 126, that applies to prescription drugs administered in an outpatient or office setting. Finally, this section shall not apply to any hospital that is designated as a critical access hospital.
Thank you. I think to Sarah's point on her graph and the little numbers, I personally asked Jen to remove critical access hospitals from that. And not to add any potential burden at all to our hospitals that we know are struggling still. Any comments, questions?
Just a clarification, CVMC is not a critical, is or is not?
It's not.
It is not.
Okay, so the first three, I'm just back at Sarah's draft, the first three, which seem to have the highest, are included in the bill.
The
Yes.
first,
Yes.
UVM,
Rutland.
UVMMC, Rutland, and CVMC, I
Yeah.
believe are.
and
It's all about Bennington.
I-
Yeah, I don't know.
Pulled up, earlier, actually, Boz's website has.
I think Northwestern is also
Useful.
not a useful.
Map.
Attleboro is definitely not.
Oh, here is the map on Boz's website, and he is down here, so light blue is critical
Oh,
access.
some kind of.
Incredible retreat is not, but.
Right, it's Attleboro. I thought they had more than 25 beds.
No, Bradburn Memorial Hospital is a Medicare dependent
Yeah,
hospital.
They have more than 25 beds.
It's
I know.
critical
I'll
access
talk to
colored
Emily.
in.
I don't think I was,
North Country is a critical access, Northwestern is not,
okay.
Copley is, Northeastern Vermont, and St. J is Porter, Manascutney, Springfield, Grace Cottage, currently not.
And not Bradman.
And if I'm looking, Northwestern didn't even register as a line.
Right.
And their ASP percentage is, am I reading this? It's the lowest of anyone except for North Country, maybe? In Blue Cross's estimation. Any thoughts or the bill will be coming to us, which had its second reading yesterday in the Senate. I will say it was a unanimous voice vote, I think, in 266 on the Senate floor. I was listening to it from
It was
outside.
a voice vote, I don't,
Voice vote. So it will be coming to us and it will have the section of in it that they put into it in weight bagging. So our options are either let the bill die, which is the 340B bill. Concur with the Senate proposal of amendment with the weight bagging in it. Or propose to amend the bill in a different way. Which we could remove the white bagging out of it and send it back over. In conversations with the chair of Senate Health and Welfare, if we sent the bill back over without white bagging in it, without something in it, the bill would not pass. They would not concur with us on that. And so we have the choice of letting it die or amending it. Or concurring on white bagging. Anyone have any thoughts?
And then me.
I absolutely think we need the 340B bill. So I would like to see us pass it, either with this language.
Yeah.
The ASP or taking out white bagging or just take. Right, we can't take out white bagging. That was that's not.
If we took out white bagging,
But this-
we would be amending it and sending it back to the Senate and the Senate would let it
Die.
would
Okay.
let it die.
Okay.
We can amend it and put our language in.
We can amend it and put our language into it.
That we like, that we've been talking about.
Yes. And in conversations with the chair of Senate Health and Welfare, I believe that the Senate would concur with this language. Thank you for resetting us. I know it actually was a long time ago, the 340B bill. Remember that one of the most important things about the 340B bill was our FQHCs and supporting our FQHCs, because this is how they are supported to serve our communities. And so it was really very important for
Can you just explain the way the bill's written now that we're being presented?
bill that Jen walked us through the other day.
No, the one that's coming from the Senate on white bagging or.
Yeah,
I was just pulling that back up.
yeah. Jen walked us through that Tuesday morning, I think was it?
I know.
Or Tuesday afternoon. It's-
Kind of confused me here.
So I think what you are looking at is, so this is the bill with the markup from Senate Health and Welfare. It was about having some restrictions on what manufacturers can do in limiting 340B contract pharmacies. There's the report on participation in 340B drug pricing program, and there were some changes there. And then they had put in a temporary ban on, or a temporary repeal of the ban on white bagging. I think that's the piece that you're talking about right now, is whether the committee is interested in agreeing with the Senate's proposal on this temporary repeal of white bagging, or making some limitations on average sales price or something. It's that piece of it, but it's all in the one bill.
I'm proposing that we remove the temporary ban. There's so many double negatives, and I don't know, that we remove.
White bagging provisions.
Remove the white bagging provisions in here, keep our ban on white bagging that we worked very hard into H233, was it? A couple of years ago on. And that keeps sort of the safety in place that others have identified as, possibly being. I'm just suggesting that we remove what the Senate has done with white bagging and replaced it with this language, because I do know the intent of the white bagging was for immediate relief to our insurers because of the exorbitant outpatient prescription drugs that they're currently paying.
So,
Mari, and then Woody.
I agree with your proposal. It's a much more, our amendment, I think, is a much more precise way of dealing with the issue. It's a more immediate way of dealing with the issue. It doesn't add complications to a payer that doesn't currently use white bagging. And it doesn't reintroduce a problem that we were trying to get rid of that we're trying to address in H233. I don't want to bring that problem back and open that back up again around patient safety and PBMs taking advantage.
Woody?
So, the white bag, it stays with hospitals, does it?
It allows the hospitals to still do white bagging, and they control,
For the security and safety.
Yeah.
I would agree with that.
Leslie?
I'm seeing this as our second emergency tool. The first one was what we talked about earlier, and here's the second one in tagging price to ASP for these drugs. I mean, they're obviously incredibly expensive and really driving. Once again, I feel like, at the risk of reiterating the obvious, it's up to us, because no one else is stepping up, not the administration, anywhere, to address our healthcare crisis. So I feel like it's really irresponsible not to do it, not to really rein in those drug prices, because the system has to find many millions of dollars in order to stay solvent. And this is yet another tool to do that. And I think it's crucial. So I will support the language with it going forward.
Did you wanna?
Do we have 266 yet?
No, it's.
Okay, so we still
reading today.
Third reading.
I just want to make sure that we go through the language again, make sure we have a good effective date, because I want to make sure if we do this, we are doing it in a way that ensures there will be a premium reduction
Yeah.
in 2026.
That's crucial.
I apologize, I have to go.
Yeah, so if you, this is not the last we heard from it, we hear from, by introducing this language, absolutely, people need to speak onto it. We'll invite in some witnesses for this, but it will move quickly because remember, when the Senate bill comes back, we've got it's on the calendar on notice. So if we need to amend it, we need to do that quickly when it comes onto our calendar. So, okay. I think we're done for the morning and we have, I promise, nothing after floor today. I know I promised that like multiple times.